My name is Pauline Heslop. I was managing the confidential inquiry into premature deaths of people with learning disabilities from 2010 to 2013, it ran. And what I'm going to talk to you today is a little bit about what the confidential inquiry tells us about health inequalities of people with learning disabilities. What we found makes people die with learning disabilities more likely to die sooner than other people, and how we can think about addressing premature deaths in people with learning disabilities. And it picks up on a lot of the issues that you have already been discussing today. Clearly, I can't go through all of the findings, so what I have done is brought with me just 2 copies of the reports that we wrote from the confidential inquiry. There's a main report and an easy read report. There's also a main summary report and a main easy read report. And there's also a DVD which was produced by your competitors, being guys. So the Misfits Theatre Group is a theatre group of people with learning disabilities from Bristol, and we worked with them and created a DVD of the findings from the confidential inquiry. So those are on a DVD. Now, I couldn't carry lots of copies with me today, so I'll leave these copies here. But if anyone does want any more copies, either of the DVD or the reports or both, then just contact me by email and I can send those out to you. So let's start. So what are health inequalities first? I'm sure you're all familiar with this, but just to remind you, they're preventable and they're unjust differences in health experienced by certain population groups. And they can be evident in relation to a number of different spheres of life. So in terms of service provision, put a picture here up of Winterbourne View. We're all familiar, I hope, with the unjust situation for people with learning disabilities in Winterbourne View. We can see health inequalities in relation to what we call morbidity or patterns of illness of people with learning disabilities as well. People with learning disabilities are more likely to experience certain illnesses. They're also more likely to experience what we call multimorbidity, so lots of different illnesses at the same time. And the third health inequality that I've touched on here is about mortality or patterns of death, and that's what I'm going to focus on today. Sorry, it's not a particularly jolly subject, I know, and it can be quite hard listening to some of this, so do take care and look after yourselves as well. So I'm going to talk to you about the evidence from the confidential inquiry, and what we found was that almost a quarter of people with learning disabilities died before the age of 50, compared with just 9% in the general population. Now, that is a huge difference, right? And Jim this morning talked about a colleague of his, really celebrating the fact that he'd got to 50, and with real justification for doing so as well. We found that the median age or the middle age at death for males was 65 years, meaning that men with learning disabilities died on average 13 years sooner than men in the general population. And we also found that the situation for women was rather more worse. So the median age at death for women was 63 years, and women with learning disabilities died on average 20 years sooner than women in the general population. Now, we also looked at whether deaths were avoidable or not. And what we found was that for every one person in the general population who dies from an avoidable cause of death, 2 people with learning disabilities will do so. And I'm going to just go into that in a little bit more detail. There are 2 categories of avoidable deaths. The first are what we call preventable deaths, preventable mortality. And these are deaths that could largely be avoided by public health interventions in the broadest sense. So an example of that might be a death from a road traffic accident in an area where there hadn't been any traffic calming measures, or a death from lung cancer caused from smoking, tobacco, where we've got generally, quite good smoking cessation programs now that should be largely avoiding that. And the proportion of preventable deaths in the general population is 21%. And that's the same that we found with people with learning disabilities. Now, the second category of avoidable deaths are those that could largely be avoided by good quality healthcare. An example of that might be a death from appendicitis. Right? Generally, we wouldn't expect people to die from appendicitis because we might hope to pick that up in, soon enough. Or a death from infection. And, touch wood, at the moment, we've got good enough antibiotics that we'd hope people wouldn't die from infection. And what we found was the rate of amenable mortality, we call it, deaths that could largely be avoided by good quality healthcare, is 13% in the general population. But in people with learning disabilities, it was 3 times that rate. It was 36.5%, a huge difference. So what we're saying is that for every 1 person in the general population who dies from a cause of death that could be avoided by good quality healthcare, 3 people with learning disabilities will do so. Now, that's a worrying figure, but on the other hand, it means we can do something about that. That this is not a situation that's unresolvable. It's within our power, all of us, to do something about that statistic. So let's think about what some of the contributory factors are that could avoid deaths that could be caused by good quality healthcare, and what can we do about them? We found that there were 5 key factors that contributed to early deaths of people with learning disabilities. And I'm going to go through these one by one, and they do touch on many of the things that you've been talking about today. The first is the issue of identifying people with learning disabilities, anticipating their likely needs, and making reasonable adjustments for them. And, it's a familiar theme. Jim's been talking about reasonable adjustments. And some of the workshops we've been talking about identifying people with learning disabilities. When we reviewed all the deaths that we did in the confidential inquiry, we found that there were significant problems in identifying that a person had learning disabilities in the first place. And that then triggered off a whole series of events that made it so that if a person was, for example, going into hospital, there was a lack of preparedness by the staff. They didn't know that a person with learning disability was coming. Therefore, there was a lack of understanding on their part about how they could best support the person. There was a lack of provision of reasonable adjustments. And those reasonable adjustments just, not only not provided, they just weren't thought through in advance of that person coming. So how can we get it right? Again, some of these issues we've talked about today, flagging, identifying that a person has got learning disabilities is really, really important. But it's on its own, it's not sufficient. We also need to make sure that that flagging system leads into the documentation of the reasonable adjustments that person's need, and that those reasonable adjustments are audited to make sure that they are provided. We'd also suggest that early involvement of any learning disability liaison nurses, community learning disability nurses, learning disability specialists at times when there are problems. What we commonly found was that it was known that a person was going into hospital and people were anxious about it, but nothing was done. And actually by involving somebody who might be in a position to help sort that out would be really beneficial. The second issue, diagnosing and treating illness quickly. Again, we've heard about that this morning. What we commonly found was that there were problems and delays not only in diagnosing illness, but in treating a person's illness. And I'll give you some examples of those. In terms of diagnosing illness, what we actually found was quite interesting in terms of what the existing literature says, because the existing literature suggests that it's difficult to recognise when somebody's unwell, that care workers maybe don't take a person for medical attention in a timely and appropriate way. Now, actually, we didn't find that was the case at all. By and large, we found that care workers, families, they knew when a person was ill, and they did take that person for medical attention in a timely and appropriate way. But that's when the problem started. There were delays then about diagnosing that person's illness, and there were often difficulties once the diagnosis had been reached in treating the person, meaning that those delays contributed significantly to the time period when a person was without treatment for their illness. As an example, we researched the death of one man who had symptoms of cancer, of colon cancer, and he needed to go for an investigation that involves putting a tube up your bottom with a camera on it, called a colonoscopy, for those of you who might know. Now, that investigation requires some preparation. You have to drink 3 litres of fluid. It has to be a specially prepared fluid. The gentleman was living alone in the community. He was fairly unsupported. He had just a couple of hours support a day. And he was sent through the post some sachets to mix up with some water and to drink. Now, this man couldn't read and write, and that was written in his notes. So he hadn't prepared the fluid. Hospital transport turned up to take him to hospital. He hadn't been fully prepared for the investigation, and so the investigation couldn't take place. He needs some help in mixing up this fluid. So a community nurse came in, helped him mix up the fluid, and he did take it, and it gave him the diarrhoea that was required. The ambulance turned up to take him to hospital, and this time he refused to go because he had diarrhoea. And he'd been told that if you have diarrhoea, you shouldn't go to hospital because it probably means you've got a bug. Now, that lack of explanation in following through with him meant that it was 16 weeks instead of the required 2 weeks for him to have that investigation. So that's a really clear example of these delays, that if that person had had reasonable adjustments made right at the beginning, somebody really understood what his needs were to prepare for this investigation, that 16-week delay would not have occurred. The example of delays in treating an illness was a woman whose death we reviewed, who developed leukemia. And when she went to the hospital, she was always accompanied by carers. Now, she didn't live with carers. Again, she was living in the community on her own with just a few hours support each week. But that support did cover her to go to hospital attendances. But the assumption by the hospital was that she had care 24 hours a day. And so when it came to developing her treatment regime, and she was being treated with medication for her leukemia, the assumption from the hospital was that her carers would help her with this medication. But they hadn't told the hospital, well, actually, no, we're not here all the time. And there was a 3-month period when this woman just wasn't receiving any treatment because of that lack of communication. Again, that lack of reasonable adjustments really mattered to this lady. So what can we do? I've already mentioned proactive referral to specialist service if there are problems with accessing healthcare needs. Use of advanced health and care planning, hospital passports, making clear what the situation and the needs of a person are. We did find that people with learning disabilities had a very high rate of death from respiratory disorders. And we've recommended that people should be treated as a very high risk group for deaths from respiratory disorders, and we need to be taking proactive measures to reduce that. So things like vaccination, flu vaccinations, immunisations for people with learning disabilities, good postural care right from childhood through to adulthood for people who require it, good easy access to speech and language and swallowing assessments, etc., etc. I've already talked about ensuring reasonable adjustments are provided and documented, and also being cautious about watching and waiting. I know it's a technique that doctors often use to just watch and wait and see how an illness develops, but that was a risky strategy in some cases with people with learning disabilities. And what we found was that sometimes doctors tended to watch and wait a little bit too long, and longer than they would have done if a person didn't have learning disabilities. We often found that people were quite anxious about going to the doctor, sometimes quite afraid about going for any sort of medical attention. And it was easier for the doctor to just, we'll just wait and, we won't do the blood test just now. We'll wait and see how things develop. Whereas actually, for somebody without learning disabilities, they might have had the blood test then and there. So that being cautious about watching and waiting was a particular issue. The third issue was about the coordination of care and information sharing. We found quite a lack of coordination of care, both between different disease pathways and service providers. Remember I said that people with learning disabilities often had lots of different things wrong with them. And what we found was that if they were a child, there was a paediatrician who was looking out for them, looking after their needs, and knew everything about them. But as soon as they moved into adult services, their heart went one way, their lungs went another way, their liver went another way, and never the twain shall meet. And that lack of holistic perspective of what was going on for the individual was really problematic. Coupled with problematic sharing of information and professionals working in silos and not sharing the information about an individual. So if Dr. X over here changed somebody's medication, it commonly wasn't communicated to Dr. Y over here. So what can we do to get that right? Well, firstly, we need to prioritise the coordination of care role for people with learning disabilities who have more than one long-term condition or who have a significant illness and are living fairly unsupported in the community. That's absolutely essential. We did find people living in particularly supported living environments where health surveillance or supervision was not seen as part of the care worker's role. And that was very problematic because there was nobody looking out for people to make sure that their health needs were being met. We've talked about communication or hospital passports. We would go further and say that some degree of patient-held health records was really important, particularly for people with multimorbidity. There's lots of different things wrong with them, to just pull it all together. The fourth issue was, and again, that was interesting to see a workshop here today, was about understanding of and adherence to the Mental Capacity Act. We found considerable problems in professionals understanding when an assessment of capacity might be required, problems with the whole best interest decision-making process, confusion about what a serious medical treatment is and when an independent mental capacity advocate should be involved. And also concerns about the outcomes of decisions that were made. So sometimes, a decision was made in the correct way using a best interest process, but then it wasn't followed up and somebody else came along and said, oh, no, we're not going to do that. And therefore, the whole decision-making process came to nothing. So what do we need to do to get it right? We felt that Mental Capacity Act advice needs to be easily available 24 hours a day for all care professionals. We were really concerned about this. Many of the problems occurred where there were junior doctors working fairly unsupported in A&E, maybe in the middle of the night, and they felt they didn't really have anyone to go to ask for advice. Decision-making processes and outcomes must be clearly reported in notes. Certainly our view was that if it's not documented, it hasn't happened. And we found very poor evidence of the rationale for decision-making in patient records. And that was really important when we came to look at do not attempt resuscitation guidelines, do not attempt resuscitation orders, which were particularly poorly documented. And we couldn't determine whether that decision had been made following the right process and with the views of everybody who was required taken into consideration, or whether it was a single medical profession making that judgment, in isolation from really understanding what was going on for that individual. I'd suggest that we saw some good examples of Mental Capacity Act training, but what we also found was that often professionals didn't really understand the relevance of that to their own situation. And what we felt was that Mental Capacity Act training needs to be followed up on the ground with some acquired practical application of that knowledge. And then finally, and certainly not least, because this is absolutely crucial, is the issue about listening to people with learning disabilities and their family and paid carers who are looking after them. We found that family members really struggled to get their voices heard. They didn't feel listened to. They sometimes felt quite intimidated by healthcare professionals. And there was a particular issue when people reached the age of 18 that family members felt even more sidelined. The person was seen to be an adult in their own right, and the views of families therefore seemed to be pushed aside. So, getting it right, recognising people with learning disabilities and carers as being partners in care, along with health professionals, really understanding and recognising and using the expertise and knowledge of family and paid carers. We also, and again it's been touched on this morning, about the issue about when family carers are in hospital with a person, and really having quite clear agreements about what the expectations of family carers or paid carers roles are when a person stays in hospital. You know, making sure they have a shower, making sure that they're getting food, making sure they've got somewhere to sleep. Being clear about what their role in the care of the person really is. I'm going to just summarise those. Now remember, these are not just the nice things. These are contributory factors to people's premature deaths, okay? This is not just about, you know, wouldn't it be nice if we could do this? This is when this goes wrong, people might die sooner than they should do. And it's really important stuff. I'm going to finish with a quote from a family that we interviewed as part of the confidential inquiry. And they told us a story about Henry, and I've anonymised Henry's name. So Henry was a young man in his early 20s, and he had epilepsy, which resulted in quite frequent seizures. And he lived at home with his mum and his sister. And we spoke to his mum and his sister as part of the inquiry. And his sister told us that Henry had collapsed at home, and they'd called an ambulance and taken him to hospital because they'd realised this was different from his usual seizures. Once he was taken into A&E, and the staff treated him as though he had had a seizure. And his mum was saying, no, I was with him. I know this is not like his usual seizures. There's something different about this episode. And Mum said that they had to fight and just really complain to the staff, saying this is not a seizure. His sister, eventually under pressure, according to his family, Henry had an MRI scan, and it showed that he had a cerebral hemorrhage, so a bleed into his brain. And sadly, he died soon after that. And his sister said to us, she said, it seems like yesterday because I felt that I had let him down, and I will always live with the fact that I think I let him down. And I let him down because although I tried hard, I hadn't fought his corner hard enough to say it's not what you think it is. You're just looking at the papers, you're looking in a textbook, he's got epilepsy, he's collapsed, you think it's epilepsy. You're not listening to my mum, and she was his main carer, but you weren't listening to her. And his sister followed up and she said, all they could say was that they were sorry. They were sorry because they'd missed it. They were sorry because it'd taken so long for them to diagnose what was wrong with him. And they were sorry because he had been in pain from 7 a.m. until 5 p.m. I think that's a really important message about listening to the views of family members and carers. And if there's one thing that I want you to take away from all of this talk, it's to do so. Thank you.